People and Digital, and item 4.1, key issues report from the Workforce OD and Digital Committee. So Tom, over to you.
Thank you. Sorry, my logging back in is just perfectly timing to jump out of.
I think we can take the
absolutely.
Read, but
no, thank you.
Some extra bits.
I guess just to draw attention to the risk, which we spoke a bit about before from a maternity perspective, just to kind of flag that. The committee is going to keep a close eye on that, along with other kind of mechanisms. We actually have kind of spoken about a couple of these wider issues today already. So a specific instance of maternity around stat and mandatory training, but also kind of the trend with sickness and PADR compliance. Obviously, these things have been a key priority for the committee for a long time. I think it's really important to recognise the actual significant developments that have been made around improving some of those kind of statistics and alignment against tier one or kind of compliance against targets from a Welsh Government perspective. Some of the wider changes, which I guess this has been a particular focus around digital infrastructure to support some of the wider workforce development work. So our reliance and dependency on ESR as a system to be able to do the things that we need to do. And I guess also what that looked like in a world kind of post ESR. So what will be the next kind of the investment in the next system. So kind of ongoing work there too. I think again, just to reiterate there's a kind of a constant vigilance piece, as you can see with some of the items around cyber assurance, broader information governance, and I guess that kind of resonates with digital leadership. So what's that look like across the organisation? I think we are in a good position as a body, as a public sector body with critical national infrastructure. I think probably we can describe like that. It's still an extremely heightened and challenging landscape for attack on digital infrastructure. So across the wider public sector and across the NHS, there is significant challenge and scrutiny on what's kind of happening and our active defence against kind of attacks for this kind of stuff. And obviously Matt's already mentioned, hopefully pending ministerial approval, continued investment more broadly across our digital infrastructure and our wider capability in this space. I probably wouldn't normally talk about this, but just to draw attention to the digital procurement policy, I think that got approved at the last committee meeting. And I think the sense of that's another step forward around how we ensure broader alignment from an enterprise digital approach. So actually in the sense of, I think there has been a bit of ad hocery in the past where people are able to purchase systems and software and develop those or use those as part of a wider enterprise piece. I think it's a real strong move to rationalise and to better understand what's being used across the digital land estate within Swansea Bay, because that sits with how do we procure software and systems. So there is I think from Matt's perspective, within Matt's team, that is part of that wider process. So people cannot just buy stuff and start using stuff. I think that is there's a cyber aspect to that, but there's also just in the sense of how we use digital and how systems and software are being used more broadly.
Thank you. Yes, really useful. Matt?
I think Tom's points are well made. What I was going to add to the conversation, and it's in the report there, the piece of work we're doing on the digital strategy at the moment. It's a focused piece of work over 12 weeks where we're actually engaging with a partner to facilitate the process with us. And we're engaging right across the organisation, making sure that we've got, the views of leads, clinical leads. We're joining many groups across the organisation to get that feedback. We went to the Clinical Senate on Friday, where we had great feedback from some lead clinicians. So it's all building to having a 10-year strategy. All right, we say 2035 to give it a round number, but what our vision is, where we want to be from a digital perspective to enable this organisation where it needs to be, but then backed up with a 3-year roadmap with a mobilisation plan of how we're going to deliver that 3-year roadmap. So it's it's not like we haven't got any of that stuff already, but our plans, I think, and with pressure, have become more of an annual plan usually. So this is a longer term vision with the 3-year tactical roadmap.
Just to say on that digital strategy, so I had a chat with them, and I know a number of other colleagues have had chats with the external consultants who are doing this. And I think it really reflects our maturity for digital. So I think if this had been 5 years ago, we'd have been we'd been having very different conversations with that external body, and they would be coming to us where I think that the type of conversation we're having, and also where we are with regards to investment and capability, I think it really reaffirms the progress that has been made around kind of our thinking about digital.
I'm going to bring Raj in a second, but it strikes me that I know this will be taken to the Workforce and OD and Digital Committee, but I would have thought YMs particularly, if not board members, would appreciate a briefing on this. Such a fundamental part of our enabling the organisation. Yeah, I can see not. So I think if we can add this to a briefing, that would be good. So Raj.
Yeah, I think Matt wanted to come back.
No, sorry, Matt. Yeah.
It's on my urge on this to speak to Hazel about getting it on board development, but if it's an IM briefing, either one's fine.
Either one. Oh, yeah, we'll take it offline, but yeah, no, great, lovely. Thank you, Matt. Raj.
No, thank you. I just want to clarify, especially with the strategy being developed. There's more and more of artificial intelligence coming in. And I should say the fact is, how do we actually govern that within the organization? How making sure that we do actually have a proper governance structure with regards to the use of artificial intelligence, because it's actually just booming at the moment. So I just want to know whether that will be captured within the strategy too.
Absolutely.
Just on that point specifically, I know, I mean, this is not just for kind of health and social care, but Welsh Government are looking at this very closely. There are kind of specific instances that have driven this, so education particularly, but I think there's a wider Welsh Government position being developed on say the use of AI kind of internally, and kind of ethics and governance frameworks around, you know, if we're going to be using Microsoft Copilot as part of our wider enterprise tools, how and when they should be used, and you know, kind of what's the visibility and transparency of those structures. So maybe as part of this wider work, there's probably, it can be useful to think about a position for the health board, which will probably change because of the fast-paced landscape. But it's like, what's the current position on AI? What's the Swansea Bay's view on how we use AI?
I think it's quite important actually, because I think there are different sectors will have different perspectives on it. And certainly our clinicians, some of them will presumably be see some quite significant advantages. So how are we going to play into that then? Can you answer that, Matt?
I haven't got the full answer right now, but we are going to have to be very soon, because, you know, this, and it's really key that we've created the Workforce and Digital Committee, because this will have such an impact on the workforce.
Yeah.
And it's something we've got to manage very carefully, because it could, you know, we talk about what you can do in the clinical space, for the whole clerical administration space, and we could turn what we do on its head and give us lots of efficiency opportunities, but we're going to have to manage that very carefully with the workforce.
And I suggest we put that as an action to sort of have a think about and come back as to how we will play in specifically for the our position on AI.
I think it fits quite nicely for my committee as well, because I really would reiterate that workforce dimension, because I think it can be feels quite disruptive for certain types of workers and roles. So the potential kind of challenge of it might be disempowering and it might be disadvantaging for certain of our colleagues. And you know, unsurprisingly, many unions are quite concerned around the impact and use of AI across various industries and sectors. So I think if we can be quite proactive about this and be quite open and transparent about how we might use it and how it can be used, I think that'd be a really good position.
Great. Angela.
Yeah, just a point. I think the engagement has been great. I think you know, we had you visiting the clinical senate, and there's been quite a lot of good engagement with the clinicians, I thought. But for me, I think it's important to know how much our strategy aligns with the national direction as well, because how much autonomy do we have in that strategy to define where we want to be in Swansea Bay, but what is actually feasible in Wales? Is there sort of an interface with the national work?
Yeah, absolutely. So, you know, the strategy will be absolutely cognizant of the national space, of the financial challenges that we have as well. We're working very closely nationally, so there's a monthly director of digital's peer group with DHCW, and there's a, you know, clear focus on what the way forward needs to be. Maybe we need to freshen our approach nationally, and all, including Welsh Government colleagues, are up for that conversation and things to progress in. So, you know, we are starting to talk about now we're not just starting to talk about, we are maturing ideas around what the electronic patient record, or whatever we want to call it, needs to be for the whole of Wales, and how we support local, regional ways of working so that we can go at this at pace. So yeah, that's all in it. Yeah, certainly there's constraints and opportunities nationally, but we have to remember, you know, as a health board, we are in charge of our destiny and we need to make sure that we're influencing in the right spaces naturally, but deliver what we need to do here in Swansea Bay.
Thanks. Jean?
I think that national picture is really important. If we bring that back down to our own health authority and we look at the challenges around finance, we look at the challenges around workforce and resource. If we optimise the use of digital within that, the savings and the productivity enhancements are fundamental to our way forward. Because where we cannot see some of the wasting spend, if we had a digital system that informs and gives that transparency across all services, then we're better informed. And if we link that to the way in which we're currently giving information in our reports, and we get better at the data analyst perspective, rather than a narrative that is 60 pages long. If we use that analysis better, then we can make, or your exec and we can make better informed decisions. So I think for me, digital is fundamental to everything from A to Z.
Was your hand up front?
It was, but it's a different.
Okay, fine.
I just want to ask, on AI, is there a definition? The reason I'm asking is that we're potentially boxing a whole load of things into under one umbrella, and I'm not sure whether that's correct. The other thing is that AI used to be synonymous with opportunity in the future. It's now synonymous with threat and maybe it's more negative connotations. And where we put that in terms of some of these developments, which as Gina said, undoubtedly will be beneficial to staff, rather than promoting AI, which might be something as seen as more of a threat and a negative thing. Whether there's a clear definition of what artificial intelligence is, as opposed to electronic solutions to solve clinical.
I think the problem is it has become, it's been like calling things digital, it kind of means everything and nothing. So I think particularly now there are things that are not really artificially intelligent in the kind of very narrow technical definition. I think that's probably within the gift of the health board to think about what, you know, we could provide a more specific definition of what we think AI looks like. There's work, you know, UK government are doing some stuff, the European Commission are doing stuff about it within the context of regulation of AI tools and technologies, but it is a very broad and open and inclusive definition. So you have to be careful because it could be any system that algorithms work on data, and that could be literally everything. So I think we need to articulate that better to our staff and to our stakeholders. And I think also we could also be very clear about positive and impactful case studies. So, you know, I think you see AI is going to be the destruction of humanity in the news. I think we could probably really evidence some use cases that can have a massive clinical, patient, staff impact and how they can be used for public benefits, not just it's going to get rid of jobs.
I can see a board paper for you.
A board paper written by ChatGPT.
Yeah, no, exactly. Give me 2 minutes. Give me 2 minutes. How long do you want it?
I do think, joking aside, I think something around the opportunities, our position, how we play in. I don't think it's, you know, it's not a tomorrow urgent type of thing, but something, it is moving so fast. And we don't want to be holding back developments that could be helping our staff provide better care. So I think it would be quite helpful to have that actually. Okay, Matt, you have another area.
And some specific. The ESR Establishment Control Project that's mentioned in the paper that's taking place within the service groups over the next 12 months. I was just wondering how that kind of talks to the systems that finance is using to establish, you know, for the establishment and the costing the establishment, and will that improve? Will that give improved information?
Yeah, thank you, Debbie.
Yes, it's ESR is an integrated HR finance system. So it's a project that we're working with in conjunction with our finance colleagues, with support from an external company, the National ESR team, and we are jointly building the establishment within the system. So it will enable us to have better budget management and also for us to manage our workforce more effectively. So it's, in actual fact, as Tom alluded to, we should be getting rid of or replacing ESR within the next few years. But this work will enable us to be on a better footing to transfer our data over. So yeah, I mean, it's the whole purpose of that project is to help us to effectively utilize our resource, our people resource.
Thank you. Any other thoughts? No? Okay, it was a good conversation. We now move on to you, Richard, to the report on delivering our 10-year vision through engagement, insight, equality, diversity and belonging.
Apologies for the table. Yes. Thanks, Chair. So the purpose of this is to update on, I suppose, changing expectations around engagement and the approach that needs to be adopted. Also just to update on the approach that we are adopting and to seek approval for some specific things that I find in the recommendations. By way of context, it's worth starting off with the new Welsh Government guidelines around engagement and the need to adopt an always-on approach to engagement, where there's a need for a systematic approach of involving patients and the public in all elements of our work and treating them as a collective voice with multiple inputs and perspectives represented. So I think that's important. Alongside that, it's worth also considering the broader role that FICE have got, where traditionally we've seen FICE as engaging with us around service change, but it's a much broader role that FICE play right now, a constructive role where they look across health and social care, and they're able to look at anything that affects patients across those remits. So I think it's really important to stress that, therefore, that despite the fact that there are different expectations and requirements, this is actually a positive agenda, and it very much fits with our vision to become a high-quality organisation and the One Thing Way, where, if you remember the vision, we focus on putting patients at the heart of everything that we do, but also giving staff a voice that counts as well. And that probably brings us back to why the Department for Insight, Comms and Engagement was put together in the first place. And that was around trying to harness the power of these voices and the power of these inputs and to triangulate sources from the data that we've got, but also the insights that we generate from staff and patients as well, in order to ensure that as an organisation we can continuously improve. So the paper and the supporting documentation outlines the approach that we're adopting there, where, for instance, there's a need for a focus on seldom heard voices. This is something that came across strongly in the recent FICE event, where they focused on making sure that we and they were hearing the voices of those that aren't heard very often, particularly within BAME communities and diverse communities across the Swansea Bay area. And that's why one of the elements of the paper focuses on the equality, diversity and belonging role, albeit subject to the INTP process, because I think it's really important that that is seen in the context of the wider sort of financial position and plans of the organisation. In terms of the insights that we generate, I think there's a need to focus on the pre-engagement side of things. It leads to co-design of solutions and services and better ways of working. So I think just in terms of what that means, so pre-engagement and ongoing engagement means, I guess, spotting the direction of travel and actually having conversations with our service users and the wider population at a much earlier stage than perhaps we would have done years ago. So that we can preempt things. And then when it comes to the point where we need to propose changes, that we're doing it from the position of already being informed about what the range of different views are. Specifically, we're asking for approval for Appendix A to the report, which is the draft interim service change performer.
So we have put that together with Price, with the local authority social services departments and the RTB, so it's the first in Wales. So that gives us a template that we can use in order to go through a sort of service change process. The other recommendations there, I won't go through them, but they're noted within the report. And I just want to finish off just by coming back to emphasising yet again that you know, this isn't a requirement sort of conversation. This is a positive conversation around the things that we can do to put the service users at the heart of what we do. There is one other element though. Clearly there's a financial context, particularly next year, which is very, very challenging. So I think the more that we can do in terms of engaging with individuals and organisations, the better placed we are there to make informed decisions where we do need to save money. So I think there's a productive element in that sense too, and I'll finish on that point.
Yeah, thank you very much indeed, Richard. And Richard and I went with Joe to the advice board meeting last week, I think it was, wasn't it? And I mean, I think that really demonstrated the value that they can bring to the conversations. It was not, it was, you know, they ran a sort of panel discussion on findings that they made on dementia. And it was not comfortable sometimes to have to answer those questions in front of an audience, but it was really very powerful, and I thought it was tremendously helpful in terms of having that continuous engagement and continually thinking about how every time we do anything, how are we going to work with patients.
It was clearly very well informed as well, so
Yeah.
they've done a lot of work, and it was very impressive.
Good. Any thoughts for Richard on the paper? Nuria.
I think the first thing I would like to say is that I really welcome the paper and the intent behind it and what you're proposing and the positivity of it all and what it enables us to do. I think that the focus on the cross-cutting issues around engagement, equalities, delivering obligations around the Wellbeing of Future Generations Act, the Welsh language, and socio-economic duties. I mean, you know that I've long expressed our view that this is something that is fundamental to us operating as a public body. So I think it is really important for us operating in the Welsh landscape in particular to have these things in one place and to be able to demonstrate the links. I really welcome the pro forma. It's something we're crying out for in terms of understanding the cross-cutting issues and the way that we assess service changes. So I think that's really important in terms of qualities duties. And the only question that I have is whether we could focus on impacts rather than services, just because it follows through from the language on equality and inclusion and engagement. And the other element for me is around not just the avoiding the negative impacts of inequalities and the equality duties, but actually moving on to the focus on the positive, on the preventative agenda, on what we do as a services to promote the positive drive to equality linked to the population health agenda, linked to us being an anchor institution. I think there's more we can draw on. The proposal on the stakeholder reference group, I full-heartedly support. I've been the independent member chairing the stakeholder reference group. I have to say that I have found it incredibly insightful. It has been a pleasure to chair those meetings, and I'm really sorry that my time commitments don't allow me to do it any further. But I think that for us as an organisation, there is so much more that we can do in terms of engagement, just from hearing those voices of the people who are trusted sources of advice in our communities. I was thinking of the maternity service, for example, and the cry for help from our staff and how those vehicles for us to communicate, having that open dialogue. And I think the time is right for proposals for us to think about our broader vision and how it links in. So I'm hugely supportive, very passionate, and I think it's the right thing to do.
Thank you. Thank you, Nuria. Pat.
Yeah, absolutely welcome, you know, increased engagement. I think this question might be a bit about my own limitations, but I kind of find the concept of pre-engagement and ongoing engagement quite hard to visualize. You know, how will that happen in terms of, you know, what will you be engaging on? What would it look like? How do you get the right kind of feedback? How do you get the right involvement in it? So if you could just practically give a couple of examples of that.
Yeah, so ongoing engagement is what it says on the tin really, which is basically to keep on talking to the public using lots of different ways and means of doing so, whether it's sort of qualitatively, quantitatively, having the conversations in broad terms about their experiences and taking on board the sort of the feedback from that, and you know, whether that's complaints, whether it's positive comments, that we get a range of different sources of data and information, and then conversations that we can have on the back of that. So that's the sort of the ongoing engagement side of things. There's always listening, but making sure it's sort of two-way communications as well. The pre-engagement is more around, we know that there are certain things coming up. There might be some distance away, but it's preparing the ground for that, to start sharing some of the challenges that we face and start asking for contributions in terms of ideas and the way that we can address those challenges. So that then when it comes to the point where we've got something specific we need to tackle, we've already got a bank of stuff that we've built up, and there's a bank of awareness as well amongst those that we've engaged with. So it's not hitting a topic cold and starting a conversation from scratch. That served us in really good stead in the last sort of year or so, where we've had a number of conversations with clients in particular around things where we haven't had to go through a full consultation process because it's been very clear, very evident. We've been able to show the evidence that, you know, we've been having these sort of ongoing conversations and pre-engagement conversations. So it's really important, and it helps us in the long run.
On the engagement on change itself, then, and looking at the performer, I mean, engagement absolutely essential in terms of service change. But of course, one of so many different factors or constraints on what you can do with that, from, you know, clinical leadership, the evidence-based, national best practice, financial constraints. I think it's important that we, in terms of communication, that the, you know, audience understands those constraints very clearly, and in terms of it limits choice, doesn't it? And you know, in terms of what the response that can be given. And I just wondering that, you know, should those constraints be very explicitly in that performer?
It's a good question. I think partly it's addressed with question number 4 in the performer, where we talk about why does the service need to change, and there's an element of bringing constraints in there. I mean, having seen a number of these types of performers being filled in for different things, I don't think individuals are slow to come forward with constraints as part of the agenda for change, etc. But I'll revisit with the team whether or not, perhaps particularly with partner organisations, if we consistently a bit more explicit around that, whether that would be helpful. So I think it's a helpful question.
Thanks, Pat.
Jean?
Can I just raise the head of appointment, which I think you've listed as 65k something or other. Whilst we have aspiration to deliver, to always move on then and improve, with that aspiration, and I think Emma, you mentioned this, there's usually an on cost. So you mentioned this appointment to the head as the on cost. But when you read through the document, there are things like the lead officer for citizen engagement, strengthening the engagement team, insight role to oversee the triangulation of data and feedback. So it's not just that 64k. So what I would like some comfort on going forward is the total cost of providing this aspirational structure, because I see the need for it, and indeed I can see the benefits derived from it, because engagement is fundamental for all of us. I just worry that when we make a statement of a singular cost, and then we make reference in the narrative to all of those other areas, we're not truly being given the total cost and the true cost.
Yeah, so the direct answer to that is that the other posts mentioned within the paper are covered within the DICE establishment. So those are posts that haven't been recruited to so far, because I came into post and wanted to review how things are working, what exactly we needed. So that money has been unspent. So it's using actually the money that's already within the budget and has already been sort of programmed for is what those posts are basically involved. the reason the 65k for the EDB role was called out was because that was additional and new requirement over and above established budgets. I can separately share the information with you in terms of the spend on the other DICE posts.
I just want the comfort of knowing that that total cost of providing this has been looked at, is there where we can put our finger on it, if you like, without incurring extra costs for the new year.
And I think the answer to that is yes, isn't it, Richard? Yeah, it's in the establishment. I think there's a difference between the establishment and what we're currently spending.
Yeah, we haven't spent
Yeah.
the money because we haven't wanted to do anything back or just press ahead with something without looking at it properly first. So, but it's there in the budget.
Excellent. Thank you. Rena, I've got Rena first and then Anne-Louise.
Yeah, I would totally support the need for the stakeholder reference group to be effective, in the sense that I was involved with it very early in my time here, and I certainly do think it's a real opportunity to, if we're missing a trick if we don't get this properly working. So I'm really supportive of that. The only concern I have on the other thing, Richard, is particularly on the head of, is given our, what we know is going to be a very difficult financial position as we come into next year. And we're going to be looking at it obviously in February in performance and finance. And I just have some reservations in my mind about some very difficult decisions that we're going to have to make, what we're not going to be able to do going forward. So I'm just having that in my mind, and I appreciate you aren't saying, you know that's part of our financial process, but I just feel we need to just have that in our mind going forward.
I'd say two things in response, if I may, Chair. So one is, it's probably worth saying that the role involves a different approach to things, where the role will work closely with Debbie's team on internal engagement. And I think that's really important in terms of particularly our overseas staff. But also, you know, we have a diverse workforce. The other element is I'm very mindful of what you've said around competing financial challenges, which is why, you know, we've said it be considered as part of the INTP process. And in that respect, you know, I'll be a member of the executive here first and foremost, rather than director of DICE, as it were, and follow the right route and look at those sort of comparisons with how else we could spend the money. So I think that's an important process. We need to come up with the right answer. I don't know what that is yet because we haven't gone through the process.
Good question and a good answer. So thank you. Anne-Louise.
I think mine is maybe reiterating the point, and in bold terms, why do we need a head of equality, diversity? What's it for? Would we get value for money? Because it's clear that equality and diversity and belonging is something that informs every appointment, the support for staff, the way in which we work. We are looking to have a diverse workforce, but it is something that comes into everyday practice, and everybody around the board is conscious of it. And whilst I don't want to reduce your department at all, and obviously you need to have external engagement, I just wonder whether it could perhaps be reorganized in a different way with different responsibility, but rather than, because there's no doubt there's noise in media about the number of jobs that are appointed to in the NHS, and whether it's the emperor's new clothes at the bottom line.
Yeah, I think part of the response to that is around, I guess, within the Swansea Bay context, we do not have a lot of resource that focuses on this area in particular. So we don't have specialist expertise. We don't have the sort of experience of engaging with seldom heard communities or seldom heard staff groups as well. So there's an element of bringing that expertise to bear, but also becoming a bit of a focal point for the agenda as well, so that we can celebrate what we do well and actually spread best practice out as well. So we don't have, you know, a team where we're appointing a head of to that team, and therefore when you look at it in totality, there's a lot of people working in equality, diversity and belonging. To be honest, right now, this is it, working with somebody in Debbie's team who spends part of the time doing that. So it's fairly slim in terms of how, if you compare it with other health boards and other NHS trusts, in fact, fairly slim would be an understatement, I think.
I'll bring you in a second, Yuri. Debbie, given that this will work with your team, I don't know whether you've got any insights to.
Yeah, I think
Yes, the board might recall that actually we had this as part of the business case when we created Life and other people looked at it. And we did make that commitment at that time from this board. And Richard is right, there are other organisations across Wales that have it, but the agenda is increasing. There's a huge focus in Welsh Government around the basis Wales and other things that are coming out. There's a lot of people within Wales. It is a role that will help us ensure we're compliant with legislation, but also ensure that we are creating a fair, equal, equitable environment for our staff and service users. My main concern normally is actually the service users.
Yes.
So that's where we don't hear. I think we're not too bad with staff, but it's really the service users.
Thank you very much. Nuri,
I think what I want to say, it was already confirmed, we've had discussions about this in Workforce and OD, we've had discussions about this, it's been picked up in audit committee a couple of times because of some limited assurance report around our equalities agenda. We're lagging behind some of our audit recommendations because of that link and have that specific staff that looks at cross-cutting issues when it comes to service change. So the need is definitely there in terms of what we're seeing at a committee level. I would also add that this is not just a nice to be agenda, this is a legislative agenda that is driven by the Welsh Government and is part of what we must do to comply with legal requirements. So I think that we have been lagging behind as a health body. I think other public bodies are really tuned up to this and it's part and parcel of what they do. That's the only thing I would say. So as I do agree that we need to go through the MTP process and make sure that it's good value for money, I think that we've had a mountain evidence as to why, as a health board, this is the right thing to do at the right time from what we see in the community.
Thank you very much, Nuria. Gareth?
You know, just you're reflecting, that maybe it's a challenge to the board, is do we really know what our service users think of us? Do we really know what this service user's experience is? Do we use that information really to develop services? I think we do it in pockets. But having the expertise, and there is a specialism to this, is that the expertise that Lights brings to this agenda is enormous. And I'd love us to be in a position whereby we put experience to the same level of safety. You know, it used to be counterintuitive, doesn't it? You can come out of hospital service sorted, awful experience, but that'll be there, you know. And I think there's something about how we really utilise this to get into those hard to reach groups and to really know what else patient service users think of us, because I don't think we've got that consistently.
No. That's a really useful discussion, really helpful discussion. So thank you, Richard. I think there is overwhelming support for the remuneration for the chair of the stakeholder reference group. I think it's been a really interesting discussion about that role. I mean, if you think back to when we agreed DICE, that is, you just really articulated it, Gareth. You know, it is about really understanding the experience and designing the services in a dynamic way that reflects both service user needs, but also changes as well. So I think this is a really important paper. I'm delighted to see it. And I think you've heard some views around the table about the head of role, but it is now into the executive domain in terms of the IOTP process. So thank you very much indeed. Good. Excellent. So we now move to the PSU report, Population Health and Partnerships. The PSU report on Population Health and Partnerships Committee. It's there as kind of read. My only observation is I do sense that this committee is starting to have some really insightful and helpful discussions. There's some quite challenging discussions as well. But you'll see the role about our role as an aggregate institution, our capacity and capability as a health organisation to deliver on our population health strategy and what that actually means for the way we go forward. And then equally the quality and nature of our partnerships and how we as an organisation can start to drive those much more effectively rather than being a passive participant, which I think to a certain extent we have in the past. How we get the right people onto these partnerships to actually drive them for the benefit of end users with the support of our partners. So it's a good committee, and I shall be handing it over to an IM fairly shortly because it is not appropriate for me to be chairing it in the long run. Excellent. Any questions? No, excellent. We then have to use Larissa report on NHS Wales partnerships and to approve the IPSR.
Yeah, there isn't really that much to draw out on this. It's more for your information as to what's been going on. The IPFR document has had quite a lot of consultation, and it came out of as a result of a judicial review back in 2021. So the policy was reviewed and revised, and has been through a lot of consultation across Wales. The major changes on it from the old one really are around technicalities, I'd say, rather than the substance of the decision making. So does that make sense? So it's about quorum and IPR membership, allowing WISC to choose the membership on the committees, invitation for other individuals to support. So, you know, there being a lot more flexibility, letting clinical experts be part of the panel. So, but it has had a panel frequency so that it brought it in line with the processes within health boards. So so that's broadly the policy. It's not out with any of the other policies. It's come out of as a result of a judicial review, but it has been widely consulted on before it went to the WISC Joint Committee in November. So that was all I was going to draw out.
No, thank you. Thank you. It was helpful. Actually, I couldn't see what had changed, but yeah, that makes sense. That's why I couldn't see.
And then so the other partnerships paper is around. Sorry, I've jumped onto my next paper.
Anybody have any?
Yeah.
So on the external partnerships paper?
Only one on the IPFR, only
Yeah.
a matter of thing. I'm just wondering, how many requests does our panel get each month?
These are for WISC, so that responds to the WISC Commission services. So those will be very, very specialist ones. We've got our own panel here, and I don't know the full numbers that go through our own, but WISC, I would imagine, would be relatively small. It's the very high end kind of clinical pioneering kinds of services that will be going through there. So I wouldn't have thought huge numbers, hence they can cover it off once a month, but I can get you that data.
I've done one in my time as a health board, not a WISC. They're very, but there's a meeting that goes in every month.
Yeah.
And it gets cancelled if there aren't any requests. Yeah. And I think I've done one in my time. So they're very rare, but it's clearly a really important process and important to be robust.
I mean, it's the real top end pioneering, like revolutionary kind of medical stuff really that should be going through these panels. And because there's such a sifting mechanism before it gets into decision making, most of the ones that do come through, I would imagine, kind of lose it. But I can get you a breakdown to demonstrate that.
Yeah, where we get more from a Swansea Bay perspective is where others want to commission services from us that we don't have a contract for.
Yeah.
So for example, some services, how that one referring to us for a specialist service that we haven't got a contract, they'll put an IPFR request through their board. We sometimes don't have quite the grip our end to make sure that we've dotted all the i's to make sure that process is completed the other end as well, to make sure then that the financial reimbursement, that we've closed the loop on that. So it's not just what we do internally, but what we receive in as a health board as well.
I can get a breakdown for you so that you can see the numbers over the last year.
Okay, before you move on to the next paper, I just need to ask for us to approve the IPFR report. We have to do that. Yeah, great. Okay.
On the other report is on external partnerships. So it just gives you an update really on what's been going on with the regional partnership boards and the more local linkages around public services boards as well. So links quite closely to the partnership committee. So those will be the subcommittees that will be attending around RPBs and PSBs. So I think we're beginning to make some real progress with RPB. I think we've got there was a review of the governance in sort of April, which was signed off, and we laboured that a little bit. But I think we've now got the right people on the committee, so we're actually beginning to make some progress. On things like NDD, so neurodevelopmental services, I've been very conscious that we are looking at just waiting lists here, and the law changed about a year, 18 months ago, where you don't have to have gone through that assessment process to access other things. And it would be far better for us to avoid getting onto waiting lists and trying to put preventative services in place. Some people will need that assessment stuff, others won't. And I'm beginning to hear that debate now coming through the governance structures of RPB. So we are beginning to see the sort of semblances of that. It was a really healthy discussion at the last SAB board that covers children's services that picks that up. So I do think we're beginning to make some traction. There's 3 committees now that have got really good strategies. So there's the learning disabilities within the mental health SAB, it's emotional well-being, which has been getting quite an airing through the RPB structures and carers. And so those 3 strategies are really beginning to synthesize the strategic direction of those committees and therefore how the RIF funding underpins that. So we're beginning to see, I think, some real traction on the way that those are working. And I think, I genuinely think relationships are improving. So, and I think we've got to open it up and use RPB as the mechanism to look at things like joint funding, how we handle CHC, so that it becomes a broader component. The conversation I've had with Samira up at NHS Wales is that the cluster stuff still kind of sits alongside. So I think there's a piece of work to do in terms of bringing the cluster and the RPB kind of infrastructure a bit closer. It doesn't have to be together, but it does need to be a bit closer so that we're looking at those needs through the same lens, so that we're using the RIF money in a really productive way. There's definitely a more preventative approach coming through those committees now. So I think we're genuinely making real progress with RPB. It doesn't feel like it's being something that's over here that's done to us. I genuinely think there's the right people on the committees, and Deb really helpfully joins me every Monday morning to talk to the local authorities, but I do think that is helping the kind of relationships, because I can't practically enact some of it. She runs some of those services, and between us we manage to not only just talk about it but deliver it. So and so I think we are making some progress.
Right, thank you. Questions? Jean?
Just an observation, Chair. Because I've made the request to better understand this goal of working from primary into secondary and seamless path for patients. I found this report very informative, so thank you for that. One of the things that concern me though is that we have a tight hold of visibility on the outcomes of these partnerships. So what are the desired outcomes? Yes, you have some narrative about what they're doing, but again, it's having that, not just the qualitative, but the quantitative understanding of how that will impact.
No, that's a fair criticism of the RPB process. The part of the problem is you had nothing to measure it against, so there weren't strategies that were in place, and therefore it was quite nebulous, and it was about who shouted loudest as to who got access to RIF. By having strategies, there's measurable outcomes. So I think the more strategies we've got in place across the RPB, the more measurable outputs. So we're not sitting at red tables just talking. We're actually having an outcome and a delivery methodology. I think that's work in progress. I don't think it's as measurable as I'd like it to be, but I do think we're beginning to get there. And if we start to get on our strategic work the indicators around population health in place, then we can start to then apply the PSB measures and the RPB measures, so that we've got something that works in a more measurable way. I think that's a fair criticism of RPBs, and I think they've been talking shops, if I'm honest, but that's not in itself necessarily a bad thing, because that's building relationships, but we've got to move that into a state of delivery so that we're actually making an impact on population, and you can only do that if you've got a strategic approach, really. So, but I do think that shift's happened.
Thank you. I've got Pat and then Angela.
Yeah, I'm just going to say, it's good to see us better engaging with RPB and the shift is great to see. I was just going to ask specifically, the ALN Act and, you know, relative responsibilities of the different involved, is that discussed in the RPB?
It should be, but I'm not sure it has been. So for additional learning needs, it's more an educational thing. It's but it would come into the neurodevelopmental area. So it is discussed in that group. So but I'm not convinced it's done and given the correct area, if I'm honest. So, but it is something that I think is an issue that is coming through, and because this is the first time we've put in neurodevelopmental as a specific committee, and has therefore got a specific focus. It's got badged under children's previously, and it just hasn't had the airtime. So I'll make sure that is being picked up in that framework, because there are quite big consequences potentially as a shift from local authorities onto health. So I need to make sure that has been kind of looked at by that committee.
Thank you. Thanks, Pat. I've got Angela, then Darren, then Tom, then Chris.
Yeah, my point is really around, you know, the importance of this, because I think to link up the whole pathway, this is so absolutely crucial to have that link and ensuring that, you know, we are aligning our priorities and our strategy. So, you know, really good to hear. I think the only bit for me is the delivery vehicle. Very often, you know, we really need to strengthen our clusters. And I think having representation from the clusters in that space to then be able to actually have the frontline people to then deliver whatever you are proposing as the priorities is going to be key, because having that engagement early will give you good outcomes.
It's bringing it together. It's starting to look at the pathway, looking at it from a patient perspective, genuinely from a public perspective. If you start designing services from public perspectives, you start to then join it up naturally, and that's why engagement is so crucial, because we think we know what the public think, but we don't. So that you've got to tie the two things together to make these things work. So the partnership is the delivery component.
I think clusters can bring that voice from exactly there quite well.
Great, thank you. Darren.
Thanks for it's a great report, great to see the detail. The breadth always staggers me this in terms of variety, depth. So my question is one about just, are we able to exercise our health views in the right spirit of partnership across all of these, in terms of the right people, the right person expertise? It feels like a huge stretch, but I know it's not just stretch. Jay goes to some meetings, some in our mental health teams, but do we know that we can deploy our influence in the way we should across all of these?
I think we're getting there. I wouldn't say, I don't think we're as influential as we could be, and I don't think we've got enough clinicians involved in the process. So I think if we could drive it more with the clinical kind of debate, so it's not managers designing pathways, it's clinicians driving pathways. I think that's probably the next step. But at least we've got more senior enough people to take decisions in those meetings, to voice a view. And in the main, these are sort of community and mental health services. The frailty, I think, is slightly different, and we will need to make sure. But Angela is very vocal in this area, so so we are bringing it in. But I think that's probably the next stage of development, so that we're exerting a kind of health component to it. So, but I don't think we've got enough clinicians involved. We've got some, but it's not driven sufficiently clinically at the moment.
I know I've got Tom and Chris, but I can see Keith at the end. And this was a discussion that we had in the partnership board, wasn't it? So bring Keith in.
So on that specific point, I was interested that Marissa's comment was all about services, because the PSBs, both the PSBs are not about services. The RPB is about services. The PSB is not. And it's the difference between treating something, which is generally a service-based approach, and preventing something, which is not. So the idea that we can somehow extend services into the prevention area is something we need to move away from. The prevention activities is a completely different model and mode of activity in the partnership space, and that's something we and if you want to read about that, I'd commend you read the anti-poverty paper that went to the Population Health and Partnerships Committee, because that sets out, I think, using poverty as a test case the difference between prevention, how you stop people getting poor, and responding to poverty, which is generally about giving people money or giving them things that they would have bought if they had money. So I think that the partnership element in the services, that's a paradigm we're familiar with. That's how this organisation is set up. We do that well. We're getting better at doing that. We're getting better at engaging. I think the other space, the placemaking space, if you want to talk about that, how we create the conditions for good health, I think we've still got much further to go. And part of that is being clear internally about how we need to behave in that space. And that's the discussion which is really starting to get some momentum in the Population Health and Partnerships Committee and getting traction across the whole of the health board, I would say. So we've come a huge distance as an organisation in the last 12 months on that journey. Still got a long way to go, but we're starting to engage with that.
So if I look at the emotional wellbeing strategy, because that's something that's been sponsored through the RPB, it's about working with communities to come up with their own solutions to develop kind of not services but responses as collectives, and that is very different to providing a mental health service to someone. So and it is about asset development and a much more social model than we've currently got. So but we're at least talking that language now. I don't think we were 12 months ago. So and I agree, this is work in progress. This isn't something that's going to happen overnight. But you can only do it in partnership. So you can't. It's impossible to do as a health board. The only way you can do it is by working with our partners to come up with collective solutions, because local authorities are actually quite good at engaging populations and they've got much better infrastructure. So I think if we can work in a more partnership forum, then that moves us forward to a much more preventative. And I don't mean that in a service provision point of view. I mean preventative as in stopping people getting unwell in the first place, or stopping them getting into the system. For mental health, it's we did a lot of consultation work about this time last year, and what the public basically said is they can't get into services, and by the time they do get into them, and they do need access to some services, they're so unwell that you've then got a very complex kind of provision. So it's a continuum, and what Keith's talking about is the very early part of that continuum. I suppose the RPB space is the middle space where you're beginning to develop service provision solutions potentially, but it is a slightly different way of looking at the world than just kind of providing a service to a problem. And I think we are beginning to see some change in the way that we're responding to that. Right.
Just to pick up on the additional, the additional learning needs issue. I think this came up in audit committee, but I remember a wider discussion around the ramifications of the new ALN regime in Wales. So I kind of know a lot about this from having led a lot of curriculum reform work in Wales. But I think it's interesting to what extent is the health boards, what does that look like from a not exposure, but as in dependency on delivering or supporting the delivery of the new ALN system and regulations, particularly that unified 0 to 25 system. So there are obviously statutory responsibilities on local authorities to provide this across Wales, but in the sense of clearly the health board is a part of that provision. Yeah. So I guess just to better understand what that looks like, particularly when we see from a funding perspective.
Yeah, I'm happy to pull that together. I'm certainly not an expert in that.
I mean, it is.
Where would that come? So it would come. We had a bit of a debate.
I can answer this one. I chair the ALN steering board for this health board. So yeah, I can pick this up. We had a long discussion yesterday in our steering board about how it fits into the RPB. But I haven't had a chance to catch up with Narissa yet since that. So, but yes, Tom, we are working through that. We've got an action plan from the audit. There are two requirements, one around the service provision bit and one around corporately what we need to do in terms of what we're going to be able to measure and report, working with Darren on that bit as well. So, so there is a plan. We've got very strong education input into that ALN group, very passionate. Where it fits into the RPB, we need to work out, because education doesn't really have a voice in there. We talked about children and young people, or the neurodivergent group yesterday. 28% of the children are probably neurodivergent, and it is up to 25. So we've got to find the best fit, but I'll actually get education into those discussions as well. I think that in terms of, I think
local authorities education ourselves, we're all aware of the financial position, we're trying to work through the best routes of having that. And there are some tensions there. And I think, but, you know, I think that everyone recognises children and young people can't suffer in this. And there's also been a large increase in demand since the change from SEN to ALN. So we have got a board, we are working through the actions, we are trying to tie it up with the RPB mechanisms with education, and we've got very, very strong education in the
Okay, because we haven't had a forum with NDD in the RPB, that's why it's got lost, so we just need to tie those two
We can
together.
decide, and so it's only a percentage of children have NDD, so I think that's the.
Okay, so that will come round, it will come into.
Can I just say-
Yeah, if you had
It came to, it was a limited assurance report on ALN, and it came to the audit committee on our latest audit committee, which is not in our list because it's the one that we just had. And we decided that as part of our governance structure, it needed to go to various committees. One, because it's in our risk register, so we'll go to the Quality and Safety Committee because they've got responsibility for that risk. It would go to the Performance and Finance Committee because it's something that they need to oversee, and particularly around the resource element of it, because we need clarity of resourcing and how that's affected the provision element of it, and who leads on what in terms of local authority and health boards and the legal requirement, and the Mental Health Committee because of our.
Okay, so I think we just need to take that off the line, so we don't have one
Yeah.
report circulating to lots and lots of different committees.
Yeah.
And I think in the terms of the RPB.
It's the NDD, that is the best fit probably, or within the children's SAB.
Yeah, and there is facility to bring education into the RPB.
Yeah, oh, they're there,
Yeah, fine. So we will take it off the line, we will make sure it gets to the right committees, but it won't be the same before going to three committees.
No.
No, good, okay, that's great, thank you very much, really good conversation there. Anything else on? Yes, Chris, were you coming in on the end, was that your?
Not the ALN was my point, I could have answered the ALN question, that's all.
Okay,
I make a lot to go do a load of work.
Decisions in action. Excellent, thank you very much indeed. So I think we've covered report on external partnerships. Exhaustively, good. Charitable funds.
Yes, so what I want to do is alert members that we had a reduction of the funds for 335k in the first 7 months. And that's due to a reduction in the investment portfolio and lower cash balance. And also assure you that the committee is looking at developing a sustainable financial plan linked to an investment portfolio as well as the new strategic approach of the trustees, and we had a long conversation about that. I also want to alert the board that following the governance review of the charity, the need to ensure consistency in relation to independent members' involvement in the charity committee is really important, and that's to aid us help with discussions around funding. And also I wanted to inform you that members of the charity have looked at current funding priorities, which include raising 160k for intensive care antenatal unit to help with refurnishment of families' accommodations, work towards renovation of the old chemotherapy unit for cancer patients as part of the 20th anniversary of South Wales Cancer Centre. And they're also supporting the Hafod Gwennell assessment unit to create outdoor recreation facilities. So I wanted to give you a flavour of the work that they're undertaking because it links directly with the work of this health.
Thank you very much, Nuria. Any questions for Nuria? Darren, I know you want to come in on the Charitable Funds Committee. No, it's a great update. Thank you very much. Darren, I know there's something you need to raise.
Yeah, thank you. It's just a contemporary update on the preparation of charity accounts. So we generally prepare the charity accounts after the main revenue accounts. We do that in partnership with Audit Wales. And as noted in the paper, the committee noted the audit plan and received that, and we progressed in that regard. An issue has arisen, and there's a bit of a story here. So we use investment company called Brewing Dolphin. Brewing Dolphin are audited by PricewaterhouseCoopers. Our accounts are audited by Audit Wales. And Audit Wales needs to seek assurance from PricewaterhouseCoopers Brewing Dolphin affairs in order to validate the content of our accounts, because there are values in our accounts driven by the submissions from Brewing Dolphin. Brewing Dolphin changed their funding system 10 months into the financial year in question. And the last 2 months have been using a system called Avalon, which is an internationally recognised financial management system. We're talking about a £50 billion portfolio of investment, of which we have 5 million. The long and the short of that range of coincidences is that Audit Wales are unable to sign up our accounts at this stage because they cannot seek assurance. The last 2 months of activities from Brewendorf have been signed off independently by Presbyterian. We're not the only health board in this division, that's here in this division, and that's in health. All of us use Brewendorf and who achieved investment status. We're very so where we are today on the deadline of submission the accounts to the Charity Commission is we're unable to do so. We've agreed and have worked closely with the Audit Wales colleagues joining us, with Audit Wales colleagues around what the handling is. So today we're submitting all of the referral reporting, but we're not submitting the accounts. So actually we achieve a deadline of sorts, but we're unable to post the accounts because we haven't got the assurance through the ISA 260 report that Audit Wales give comfort. The other supporting piece of information to share, which is positive, is that the audit of our account is complete, and that audit has shown that we've got very good governance on the account and no material matters. So in a sense, we're all good. And as soon as the assurance comes through that PwC have signed up the governance processes, that will flow through, and then we'll have to stand up the Charitable Funds Committee and the trustees meeting to take the governance through. So that's been happening since the report here today, and I thought it was important to record that.
Yeah, thank you.
Just a principle.
Do we have a date when that's likely to be?
Yeah, we expect it to come through in February. We've exchanged not too much data for the board. We're in active contact with Brewendorf, and they provided correspondence. We've shared that, but it's not quite hitting the mark, so we're still pressing and actively involved.
Okay, really update. Any questions? No, no, that is what it is. It will be a matter for the charitable trustees in any case, won't it?
Does that give us concern in any other area of the organisation? Only as a charity?
Our accounts are clean and prepared in accordance with standards. But what Wales can't do is get independent assurance of Brewendorf's approach to their financial management. It's never been an issue.
It's very specific, very, yeah.
And then there are 55 charities in England who use Brewendorf and who haven't come across this matter. But we are in open dialogue and the discussions with those companies.
Okay, great. So we now have the PSC's report from the Audit Committee.
Informed members, so we had a brief discussion about the structured assessment of the November Audit Committee and the management response in our January meeting. The report on the response of the agenda, so I don't suggest that we go into any detail now, but we pick this up as part of the agenda items. I'd like to alert members of the limited assurance report we received on estates, and that will be going through our governance arrangements. I would like to advise members that there is growing concern on the committee around the level of overdue recommendations, particularly around limited assurance reports. And the committee is particularly frustrated at the stage where we have challenged and seeked assurance over timescales being over optimistic, but keep getting recommendations passed every year. So we would like management to really look at those timescales and make them realistic. And I will hope that the board will endorse the message of that we need to get better at being more realistic about the long things take and prioritizing the actions we commit to, particularly in relation to our limited assurance reports. So we'll assure members that we will keep asking questions about realism and holding ourselves to account for the delivery of those actions.
Thank you. Thank you very much, Nuria. And this is not the first time I've growled about the achievement of limited assurance, achievement of actions against our action plans. I think it's the first time we've come out with it's as much about being realistic and focused about what our actions should be, and realistic about the timescales. So if I could urge, and this is, I'm afraid, an urge from the independent members to the executive, to make sure that that is the case, because it is not acceptable that we have these outstanding, and we're just shooting ourselves in the foot apart from anything else.
On that point, Emma, I wanted to also alert the board that one of the things that we are finding in the audit committee is that we do tend to not be very specific when addressing audit recommendations, whether it's internal or external audit recommendations. We tend to talk about everything we need to put in place before we actually address the specific recommendation they're asking us to address. And I think we just need to be more specific and smarter, because the risk of that is that they remain in our tracker for a very long time, and then we have overdue agency result of that, so that's piece of from the audit committee that I would like to share with members, but I don't know whether there's any other independent members that want to say anything around that. It was a discussion that we did have in the audit committee. Louise?
Yeah, I would add, sometimes I think there are too many words in the actions, and it needs to be much shorter and more specific. And the other thing is, it's such good news when something comes in before the due date. It's something to then celebrate, instead of the criticism that you've just issued, that often we overshoot it. So to a certain extent, there is merit in making a more realistic, slightly longer term date.
Within reason.
Within reason. Or we'd be onto them if it's not reasonable.
Excellent. Okay. Lecture over. Thank you. Nuria. Sorry. Sorry.
No, all I was going to say is I sometimes think that we probably put longer dates on when, as Nuria said, you could get a result in a shorter period of time. What irritates me is that things just sometimes drift. Yeah, as opposed to being resolved there and then, and we can move on. So I would echo the point, because sometimes we've had reports come back to us because there were certain things still outstanding. Do you see what I mean?
Yeah.
Whereas most of it was done. So it's just tightening it really.
Dan?
I just wanted to make a point of clarity on the estates narrative.
Yes.
In fact, there's two things in play here. One is the local estates regional report, which is the assurance to follow it. And we've worked hard to move that to a point where there's only one outstanding action, and that's related to our inability to recruit somebody with waste expertise. So that's a bit niche, but that's a very specific journey we've been on to help them.
Yeah.
The note here is about North Wales estate, which found actually goes into practice in Swansea Bay and the condition of the estates, the survey we done and having a strategy. But all that report was not limited nationally because of the lack of resource to support that.
Yeah.
So it's not a criticism of local, it's actually very, very helpful to have that recommendation as we drive the discussions. But it's not a reflection of local estates performance, it's a reflection of resource. I just wanted to draw the distinction between the two.
No, and I think that's important. Thank you very much, Darren. Okay, thank you, Nuria. I would like to take this opportunity to welcome Sarah Uckley from Audit Wales. Hi, Sarah. Thank you very much. Sarah's here for the next item, which is our structured assessment report. Did you want to say a few words up front, Hazel?
Yeah, just to say this is part of our annual process. Audit Wales come in and take the annual audit, annual structured assessment. Just like to thank Sarah on behalf of Audit Wales in terms of working with us. Always very professional. And I think Sarah's fed back to us as well actually about our management response probably does need to be a little bit more focused, and we had that discussion at Audit Committee. So we will be doing that as well, really. I think it's important to recognise the report was at a point in time. The fieldwork was more or less done around in the summer of 2023. So issues identified in the report that have probably moved on, and we've had some discussions around orthopedics and victim as well as doing today. So I suppose those are the things I wanted to highlight. It does more or less correlate with the board effectiveness report we had from Deloitte as well, in terms of our actions, and I've put together the structured assessment actions and the actions from Deloitte into our board effectiveness action plans to take forward to 2024. So I just pause there and bring savings.
Yes, thank you very much, Hazel. Over to you, Sarah.
Thank you, Chair, and thank you, Hazel. So just taking the papers as they come in your pack. The first one is the annual audit report for the Health Board. I will assume members have read the report. It's a summary of all the work that's been undertaken by Audit Wales in the year across our accounts and performance audits. So nothing in there is new, as it were. It's all things that have already been through Audit Committee and the relevant clearance processes. Again, I'd just like to thank my thanks to Hazel and also all the team for helping to undertake our audit throughout the year. I'm happy to take any questions on the annual audit report, and then I'll move on to the structured assessment, if that's okay, Chair.
Yes, thank you very much. Any questions on the annual audit report? No, I think we can take that as read. Thank you, Sarah.
Thank you. So the structural assessment report, again, I will assume members have read the report, but if I could just highlight some key points from that. So this is our annual review. We look at the corporate approaches to the systems of assurance, planning and financial management. We are also undertaking a deep dive on financial efficiencies at the minute, and that's due to report in March. We've highlighted a number of positive areas in the report in terms of the board assurance framework and how that's continuing to develop, around performance management arrangements and how they've been strengthened, and the balanced scorecard approach as well. We've highlighted, generally good corporate planning arrangements with new strategies such as the estate strategy and population health strategy being well written. And we've also highlighted clear processes for financial planning and monitoring the financial position. As with all audit reports, there's probably some areas that we feel it could have a bit more focus. We've highlighted around maybe further promoting the board in the annual general meetings, using social media, and also some policies that need to be updated on the website. Having noted the good population health strategy, I think again that could be more publicly promoted as well. We've also talked around board walkarounds and the need to increase the frequency and just a bit more consistent approach in those, and also reporting of the outcomes of those to Quality and Safety Committee and to demonstrate any actions being taken in respect of anything that's been highlighted. In terms of performance reports, we've highlighted the potential for a greater focus on primary care in there, and also around overseeing the other strategies as well and how they're being developed and how they're being delivered against the plan could be strengthened as well. We've made 10 recommendations, and Hazel's alluded to the management response, and we've been working on that and taking on board Nuria's comments as well as when we took this to the audit committee. Again, can I just thank Hazel and the team and everyone involved in this for setting up these meetings, dealing with all the information requests. It is very much appreciated, and I'm happy to take any questions in the detail in the report.
Thank you very much, Sarah. Any questions? I mean, it's a really important report for us, and it forms, as Hazel said, with the board effectiveness review, in a sense, our board plan for this year. So, and of course, we have considered it in previous meetings. Jean,
I guess this might be my naivety, but the point about the board assurance framework and the fact that there are controls and assurances for the delivering care in safe and modern environments objective are rated as limited with no clear action in place to address this. Could you talk around that a little more?
Yeah, of course. So we've made a specific recommendation. I think as the organisation, as the health board's been developing the board assurance framework, one of the things they've been doing is kind of looking at whether or not there's reasonable assurance against the controls in place against every particular aspect. And that was one that we highlighted, that the controls were limited, and we wanted the health board to look at that again, to go, what other things can we put in place to get a bit more assurance on whether or not we're actually meeting that. So that was one specific area. So I think the board assurance framework's on a little bit of a developmental journey, as it were. It's evolving and it's continuing to be reviewed and strengthened every time. So I think, as Hazel quite rightly pointed out, structure assessment is a point of time assessment, and then that was a bit of an area that we felt that they needed to address. So it was the controls in place against that needed to be looked at and strengthened a little bit more. But we did want to give credit to the organisation for the work on the board assurance framework and how that's developed over time.
Maybe I haven't asked the question in the correct way, because what I was getting at was, if because of the work that we've been doing on the board assurance framework, was there anywhere or any way in which you would have sort of prompted us with certain things that we could have been doing, or did that happen in the dialogue between the two parties?
Yeah, I think that's happened as part of this process, but also we are subject to an annual review by internal audit as well on risk management and the BAF. So I think the BAF has been developing over probably a few years now. So I think it's in a position now where we are actively using it. There's still some further work to be done, and that Len, head of compliance, is working on that, and that will come to audit committee in March and the board in March. So you'll see a more evolved version as well, picking up on the points that audit really
picked up, and we get lots of good scrutiny from audit committee independent members. So they've really helped us to evolve that as well.
Yeah, thanks very much.
Thank you, Jean.
Muriel? I would just on the record like to thank Audit Wales for the work that they've done around the strategic assessment, and our executives for taking the scrutiny and for amending the report and for changing the management response, because we do provide them with a lot of scrutiny at the audit committee meetings, and it is really great to see the change that, and as it happened, it's become a lot more specific, and I think it's something that can really hold you to account. So thank you both for working. I think when you sit in the audit committee, what you want is no surprises. And there wasn't anything there that surprised the committee that we weren't already on top of. So that gave us a lot of assurance that I wanted to share with everybody. And I just think that we're getting better as an organisation, but it is a journey, and it's a journey of improvement, which is great to see.
Thank you. Thank you, and thank you, Sarah. We do value the process, and we recognise the importance of the relationship that you bring to the table, and the constructive challenge that you provide us with, and we welcome that. So thank you very much indeed.
Thank you. Thank you for your time today. Appreciate it.
Okay, we are now on to the report on corporate governance issues.
This is part of a routine report that just updates the board into matters considered in committee, well, how to do the business side of the policy, the register, and it's just there for the chair.
Thank you. Any questions on that? No? Great, and the health boards advisory groups?
Yeah, so we're required to have 3 advisory groups. The 3 have met since we last met as a board. I think I won't go into the stakeholder reference group because we've discussed that previously, and that's being taken forward in a different way now. The health board partnership forum really does seem to be working well. They have a lot of good discussion, lots of good presentations there. Update on Race Wales action plan, Speak Up Safely, continuous flow initiative, national staff survey, workforce metrics. I think the health professionals forum will probably need some support, and I'll link in with Judith and Andrew in terms of maybe where they can go and next steps to evolve that meeting.
Chris, I don't know whether you've got any thoughts on that.
Yes, again, we're supposed to have a meeting later this week, but I think it's been put off, but we are looking at that. They are also engaging with Betty Cadwallader, who are a very good health professionals for, and they're attending a meeting and having a discussion with them. I think around some of the membership, again, we need to look for the broader, some of the professions. Medicine is a particular one, an area that we need input from, and that's still going on. And also, I think in terms of reaching out to the contracted professions, because they're supposed to be in there, and it's been like sporadic attendance, so we need to pick up more on that. But we're coming up with an action plan. Judith and
it's not for want of enthusiasm from the co-chairs, is it? Yeah, they've really put their effort in.
They are really working hard on it. So I think, yeah, and it is developing. The discussions are getting better. They are wanting to get much more in the strategic planning rather than delivery of pieces of the engaging, you know, and being delivered to them. So they are working very well at it.
Okay, thank you very much. Any other questions? No. Okay, I think we've now reached any other business. Does anybody have any other business? No, in which case, thank you very much indeed. That's the end of this public board meeting.